everyone. In this video, we are going to discuss about the part 3 of respiratory assessment. In my previous video, I have discussed part 1 related to history taking related to respiratory assessment, and in part 2, I have discussed the inspection and palpation method of respiratory assessment. And in this video, I am going to discuss about the percussion and auscultation method of respiratory assessment. I am Mrs. Julian K. Thomas, faculty working in M College of Nursing. Objectives of this video include: the group should be able to demonstrate the methods of physical examination, which includes percussion and auscultation of respiratory system. The respiratory examination or lung examination is performed as a part of physical examination in response to respiratory symptoms such as shortness of breath, cough, or chest pain. The elements of respiratory assessment include a thorough history collection, physical examination, and other investigation. The four main steps of respiratory examinations are, or the techniques involved in respiratory assessment are, the inspection, palpation, percussion, and auscultation of respiratory sounds. The elements of respiratory assessment include history collection, physical examination, which includes the four techniques: the inspection, palpation, percussion, and auscultation, and the investigations, which is related to the respiratory system. As we have discussed earlier in the video, the equipments for the respiratory assessment include a stethoscope, inch tape, marker pen, and a peak flow meter. In the previous video, we have seen the inspection and palpation of the respiratory system, and in this video we are going to see about the other two techniques of respiratory assessment, that is percussion and auscultation. Percussion is used to assess the density of the underlying lung tissue. It helps to determine the tissue is predominantly solid or it is filled with any air or fluid. Percussion also enables to identify the extent of the lung field, that is, and it is also useful in assessing diaphragmatic excursion, that is how far the diaphragm is going down, and it will help the thoracic cavity to enlarge. The normal percussion note over the adult lung field is called resonance. So the percussion is the method where the examiner will be striking the plexar over the pleximeter to identify the density of the underlying lung tissues. So beneath the lung tissue, whether it is solid in nature or it is filled with any fluid or air. This is the method of percussion, how we have to go about it. So in percussion, the striking the body surface will be done in a zigzag manner. So we have to percuss and see for the density of the underlying tissues anteriorly, posteriorly, and also in the lateral surfaces. So anteriorly we will be starting from right above the clavicle. So we will move in a zigzag manner. So zigzag manner, we are striking the thoracic cavity to elicit the density of the underlying lung tissue, whether it is solid or it is filled with air or it is filled with fluid. So whenever we are doing a percussion, the percussion should be done anteriorly, posteriorly, and on the lateral surface. So the normal findings of a percussion in the thoracic cavity or in the lung field. So we have to percuss over the shoulders and anterior, posterior, and lateral intercostal spaces. So the normal findings on percussion is resonance. So what is the abnormal findings? So in case if there is an emphysematous lung, we can feel the hyperresonant sound. Dullness in case of any solid mass or fluid, example in case of pneumonia or pleural effusion. When we percuss over the posterior or for the diaphragmatic excursion bilaterally, the normal findings will be diaphragm, normally it descends 3 cm. So what is the abnormality we can identify? If it is less than 3 cm, if the diaphragm is going down it is less than 3 centimeter, which indicates there is an atelectasis or emphysema or ascites. So atelectasis is collapse of the lung, or emphysema or ascites when there is a fluid collection in the peritoneal cavity which will prevent the diaphragm to move downward. So in that cases, the diaphragmatic excursion, so the diaphragm cannot descend beyond 3 centimeters. So it will be less than 3 centimeters. So how to assess the diaphragmatic excursion? So have a patient take a deep breath and fully exhale, then percuss the level of the diaphragm and mark. Have the patient to take a deep breath and hold it, then percuss at the level of the diaphragm. So measure the distance between the two marks, and the normal measurement should be 3 to 6 centimeter of diaphragmatic excursion. So in case if the patient is having any ascites or emphysema, or if the patient is having atelectasis, the diaphragm cannot move beyond 3 centimeters. So which indicates that there will be a decreased diaphragmatic excursion. The fourth technique in respiratory assessment or the physical examination include auscultation. Auscultation is the method of examining the breath sounds using a stethoscope. So whenever we are doing an auscultation for the patient, we need to instruct the patient to take a deep breath through the mouth. So whenever we are auscultating with the help of stethoscope, instruct the patient to take deep breath through the mouth. So during auscultation, auscultate for the breath sounds over trachea, the large stem bronchi and the lung periphery. So when we auscultate over the trachea, the bronchial sounds can be heard over the trachea. So the deviation from normal, which indicates the bronchial sound heard over the lung periphery, when we auscultate over the trachea, it is abnormal. Then auscultate over the large stem bronchi. Normal finding is bronchovesicular sounds over the main stem bronchi. So when there is an abnormality, the bronchovesicular sounds can be heard over the lung periphery or on the sides of the lungs. Then auscultate for the lung periphery. Normal findings is the vesicular sounds can be heard over the lung periphery. That is a normal finding. But in abnormal conditions, decreased breath sounds can be heard. So when we auscultate over the trachea, we can hear the bronchial sound. So over the lung fields, we can hear the bronchovesicular sounds and the vesicular sounds, and all over the lateral surface of the chest also we can auscultate for the vesicular sounds. So whenever we are auscultating, we have to instruct the patient to take a deep breath through the mouth. So what is the characteristics of the breath sounds? So the characteristics of the breath sounds can be explained in the terms of pitch, intensity and the location where we can hear the breath sounds, or the inspiration and expiration ratio also. So we have three normal breath sounds, that is vesicular, bronchovesicular and bronchial breath sounds. So in vesicular breath sounds, if you see the inspiration expiration ratio, the inspiratory ratio will be more than the expiratory ratio. The pitch will be low, the intensity will be very soft, and the location we can hear this vesicular sound most of the lung field. Coming to the next breath sound, that is the bronchovesicular. The ratio, if you see the inspiration and expiration, that is almost equal. Inspiration and expiration will be equal. The pitch will be medium, the intensity will be medium, and the location where we can hear this bronchovesicular sound is the main stem bronchi. And the third breath sound is the bronchial. Here the inspiration and the expiration ratio, the inspiratory ratio will be less than the expiratory ratio. The pitch will be high, the intensity will be very loud, and the location we can hear this bronchial sound over the trachea. So these are some of the abnormal breath sounds. So abnormal breath sounds, otherwise it is known as adventitious breath sounds. So these are some of the breath sounds we can hear in case of any disease conditions throughout the respiratory system. So the first one is crackles. So crackles, that is a popping, discontinuous, may be affected by coughing. So whenever the air passes through the fluid, that can be manifested as like crackles. So the inspiratory and expiratory ratio, if you see, the inspiratory ratio will be more than the expiratory ratio, and it is more prominent on inspiration. The common conditions where we can hear is the chronic heart failure or atelectasis, pneumonia, interstitial fibrosis. We can hear this crackle sound. So where we can hear this crackle sound is that over the periphery of the lungs. And the second one is ronchi. Ronchi, otherwise it's like a snore or gurgle like sound. So here the inspiration and expiration ratio, it is more prominent on expiration. The sound will be more prominent when the patient expires. So the common condition where we can see this ronchi is pneumonia. So the location where we can identify ronchi is larger airways. The third one is wheeze. Wheeze can be mild wheeze or moderate wheeze. So whenever air passes through the obstructed airway or constricted airway, the wheeze sound comes. So here the wheeze sound can be more prominent on expiration, but as severity increases, it extends through inspiration and expiration also. So the common conditions where we can hear the wheeze sound is asthma or asthma related to any cardiac problems. So the location where we can identify this wheeze is smaller airways. So this wheeze is a musical, high-pitched, continuous whistling sound when air passes through a constricted bronchi. So the other adventitious sounds also include moderate wheeze, severe wheeze, and the other one is known as the friction rub. So these are high pitched scratching or squeaking sound which is continuous and it is not affected by coughing. So the friction rub can be heard both in inspiratory and expiratory phase of respiration. The condition where we can hear this friction rub is mainly when there is any inflammation of the pleura, that is pleuritis or pleurisy. So the location where we can hear this friction rub is the affected area. So during auscultation, certain abnormal vocal sounds also can be identified. So transmission of voice sounds through a healthy lung tissues is normally muffled. So if the lung tissues is consolidated, it produces clearer transmission of voice sounds. So certain abnormal voice sounds we can elicit when we are doing an auscultation is, first one is egophony. So in egophony, how we can assess is how the patient to say E will sound like ah over the affected area. So whenever if the patient's lung field is affected, so if we ask the patient to say E, it will sound like ah. So the second one is bronchophony. So bronchophony, we have to ask the patient to say 1, 2, 3. So the clearer transmission of spoken voices sound over the affected area. But if the patient is not having any problem in the respiratory system, the sounds will be usually muffled. But if the patient had any problem in the lungs, or if we have some affected area, it sounds 1, 2, 3 will be clearer when it transmits through the lung surface. And the third one is whispered pectoraloquy. So have the patient to whisper 1, 2, 3. There will be clearer transmission of whispered voice over the affected area. So usually the vocal sound should be muffled and indistinct through the stethoscope. Bronchophony, egophony, whispered pectoraloquy can be clearly heard when there is a consolidated lung tissue, or when there is a pulmonary edema, or when there is a pulmonary hemorrhage. So in the procedure of auscultation, we should auscultate for adventitious sounds. So the normal findings, there should not be any adventitious sound heard. So what are the abnormal adventitious sounds we can heard is that crackle in case of pneumonia, congestive cardiac failure or emphysema, or in case of pulmonary edema, or wheeze in case of asthma, COPD or bronchitis. Then we need to auscultate for the altered voice sound. As we have discussed, the certain abnormal voice sounds which we can hear during auscultation is bronchophony, pectoraloquy and egophony. So usually the normal findings, the sounds will be muffled, but in case of any conditions which is related to the respiratory, if the lungs are affected, the sounds will be loud and clear. So to conclude, the ability to carry out and document a full respiratory assessment is an essential skill for all nurses. A prompt initial assessment allows immediate evaluation of severity of illness, and appropriate treatment measures may warrant instigation at this point. So physical examination plays a vital role in identifying and verifying the symptoms experienced by the patients. So all nurses should possess the skills of doing the physical examination related to each system. So physical examination helps to find the objective data or signs to confirm the diagnosis. So these are the references. Thank you.